First of all, Assalamu alaikum. I would like to thank Dr. Saeed and the organizing committee for inviting me to present this talk. I hope it will be short and informative talk. Pediatric lymphomas, as we know, it's one of the most common types of lymphomas or tumors in the children. It is the third most common tumor after CNS tumors and after leukemias. And it's represent around 15% of the pediatric tumors. In the United States, there is around 2,000 cases of kids that are diagnosed first time for lymphoma every year. And I consider lymphoma and leukemias are one of the biggest achievements in the cancer treatment in recent years. 4 or 5 decades ago, these neoplasms were fatal. Those kids will be, it's like a death certificate when you call patient or you diagnose a child with Burkitt lymphoma or classic Hodgkin lymphoma. Nowadays, most of these children are cured from their diseases. The cure rate reached now 85% in these cases. This graph shows you the incidence rate in relation to the age in the United States. And as you see, in the less than 5 years or less than 4 years of age, Burkitt lymphoma is the most common neoplasm in this age group. And generally, lymphomas in this age is not common in comparison to the slightly older kids. Between 5 and 19 years, the classic Hodgkin or Hodgkin lymphoma in general, they take the lead as the most common lymphomas on these ages. Usually, they are followed by diffuse large B-cell lymphoma and anaplastic large cell lymphoma. These Burkitt lymphoma, Hodgkin lymphoma, and anaplastic large B-cell lymphoma, they were already, you already heard about them during this course. So I will talk about the rarer entities, these new entities who have been recently described in the WHO. These entities may present a diagnostic challenge for the pathologist, especially those who are not familiar with them. So I will provide a quick overview of these entities. I will rely mainly on the WHO 5th edition. As you know, there is 2 classifications now for lymphomas, the WHO classification and the international consensus classification. In lymphoid neoplasms, the difference, according to some studies, affect just less than 1% of the cases. So there is no need to confuse you about these 2 classification. I will adhere with the WHO, which is I used it daily in my daily practice. So the first entity, it is the pediatric follicular lymphoma. Pediatric follicular lymphoma is a localized mature B-cell lymphoma that occur primarily in pediatric age patients, usually from 8 to 36 years of age. The median age is 18 years. Some reports reported these cases in older age group. However, they are very rare in older age groups. It is characterized by the absence of the defining molecular features that we usually see them in the classic follicular lymphoma, which are the BCL2 and BCL6. Also, there are the other molecular signature, the IR4 gene rearrangement, which is defining another rare entity, which we will come to it later. These entities are absent in this groups. Almost all cases of pediatric lymphoma present as a limited stage peripheral disease, usually involving one lymph node or a single lymph node group. Mostly these lymph nodes are located in the head and neck region. There is case reports of inguinal, femoral, and axillary lymph nodes reported. There is no intra-abdominal lymph nodes so far being reported in the literature. Extranodal presentation is excluded by definition. You don't, if you have any extranodal case, according to the WHO criteria, you don't call it pediatric type follicular lymphoma, although some case reports in the literature have been describing pediatric T-cell lymphoma in extranodal sites. Generally, pediatric T-cell, pediatric type follicular lymphoma, usually they have excellent outcome. The survival rates almost reach 100%. And the usual treatment is conservative in those children. They just excise the enlarged lymph node and they put the patient on a watch and a wait scheme of management. The histological presentation of the pediatric type follicular lymphoma, it usually comes as exclusively follicular pattern of growth. These follicles usually grow in serpingeous or floral enlarged back-to-back follicles, and they usually involve part of the lymph node. As we see here, this is normal lymph node. This is the neoplastic lymph node. This appearance has been described as node-in-node appearance. When we examine these cases on higher power, we see the germinal centers lack the normal zonation. We see it in the follicular hyperplasia. Usually they have monotonous proliferation, and they usually have a lot of macrophages, tangible body macrophages giving the starry sky appearance, sometimes mimicking the Burkitt lymphoma, especially in trough biopsies. And the mantle zone area is usually attenuated or absent in these cases. On cytological level, usually the infiltrate contains composed of medium-sized blastoid-looking cells with no features of centrocytes or centroplastic morphology. In immunohistochemistry, these cases usually have BAM-B cell markers positive. I put here two micrographs, one for classic follicular lymphoma in the upper photos, and the lower photos are the pediatric type follicular lymphoma for comparison. So this is CD20 in the pediatric follicular lymphoma. It is positive. And the germinal center markers, the BCL6 and CD10, generally are strongly positive. This is the BCL6, sorry, this one. This is the follicular lymphoma, which is also positive, the classical one. The CD21 and CD23 usually highlights the follicular dendritic meshwork, which is preserved in these types of tumors. BCL2 is negative. This is one of the important immunophenotypical differences between pediatric type follicular lymphoma and classic follicular lymphoma. This is the BCL2. We see here it's negative within the germinal center. However, in the classic follicular lymphoma, the BCL2 is expressed in the germinal center. Another difference is the Ki67 proliferation index. We see here the classic follicular lymphoma, usually they have low Ki67 except for high grades. However, in the pediatric type follicular lymphoma, Ki67 is very high. The IRF4 is typically negative. This is important as in the differential diagnosis. There is a new marker have been described in recent literature to differentiate between pediatric type follicular lymphoma and follicular hyperplasia. It is the FOXP1 immunostaining. This is usually nicely positive, show nice nuclear positivity in the pediatric type follicular lymphoma with complete negativity in the in the florid hyperplasia. The most important differential diagnosis for pediatric type follicular lymphoma is the florid reactive follicular hyperplasia. The most important differentiation relies in first the preservation of the architecture. You will find the preserved sinuses, preserved mantle zone, and the germinal center will show nice polarization. If you did molecular staining, you will see that the reactive follicular hyperplasia are polyclonal. However, the pediatric type follicular lymphoma is a monoclonal disease. The FOXP1, if you have it, is very helpful in this differential diagnosis. Follicular lymphoma is mostly older, comes in older age group. It's usually present with higher stage 3 or stage 4 multi-systemic disease. It's usually present with B symptoms, so clinically they are different in the clinical presentation. BCL2 is by default is positive, except in the higher grading follicular lymphoma. And the most important thing is the presence of the BCL2 and BCL6 G rearrangements in the follicular lymphomas. The other differential is large B-cell lymphoma. I will skip it until we will until next slides. I will talk about this one in more details. The next in the differential diagnosis is the pediatric nodal marginal zone lymphoma. This is a new subtypes in the recent WHO classification, and probably it will not last till the next classification. Pediatric nodal marginal zone lymphoma is a primary nodal disease and usually presents in the head and neck region for mostly in adolescent boys. It has almost 20-to-1 male to female ratio. Although it shares some features with the nodal marginal zone lymphoma, it has different clinical and histomorphological features, which made the WHO team to put it in a different subtype. Pediatric nodal marginal zone lymphoma usually present as a stage 1 or stage 2 disease, mainly affecting the head and neck region. Splenic and extranodal zone lymphoma in children are rare, and when they have it, it is not within the, you shouldn't put them under the pediatric nodal marginal zone lymphoma group. And it's usually lack the MALT-G rearrangement, which commonly you see it in the extranodal marginal zone lymphomas. Most patients with pediatric nodal marginal zone lymphoma, they treated conservatively with excision of the enlarged lymph node and they put under watchful waiting for the and usually they don't recur after that. At low power, the pediatric nodal marginal zone lymphoma present with enlarged follicles, and these follicles usually have expanded marginal zone area, and this marginal zone area extend into the interfollicular area. This marginal zone is, we can recognize it from low power by being a pale area, as in this here it's usually in low power became like a pale area because it has abundant clear cytoplasm. There is also what we call it BTGC-like features as the mantle zones start infiltrating the germinal center. The sinuses are generally attenuated or obliterated. On high power, we can see the neoplasm is mostly composed of polymorphic medium to small lymphocytes with monocytoid appearance. We mean by monocytoid, it is the cells which have abundant clear cytoplasm and rounded nuclei. Generally, these neoplasm have a lot of blast cells, either centroblasts or plasmacytoid, plasmablastic looking cells. It's more frequent in the pediatric type more than the classic marginal zone lymphomas. In the immunophenotype, generally the tumor is positive for CD20 and other BAM-B cell markers. The BCL2 is positive and CD43 is expressed in most of the cases. This is a big difference between the pediatric type and the classic marginal zone lymphoma. In classic marginal zone lymphoma, nodal marginal zone lymphoma, CD43 is generally expressed in few cases. This is the immunostaining for IgD. We can see the mantle zone cells start infiltrating the germinal center, mimicking the progressive transformation like pattern. However, these mantle zone areas are also obliterated and infiltrated by the marginal zone cells. And this is major difference from the BTGC, progressive transformation disorder. So the differential diagnosis mainly relies in these two entities. The first one is atypical marginal zone hyperplasia, which is a rare polyclonal expansion of the marginal zone. We see it usually in the extranodal sites, in the tonsils, in the GI, and usually doesn't involve the lymph node. However, rare cases of nodal involvement have been reported with Haemophilus influenzae infections. They usually CD43 positive, like the pediatric type marginal zone lymphoma. However, when you do a molecular study, you will see these cases are polyclonal. Pediatric type follicular lymphoma is the other differential diagnosis, especially in the pediatric age group. Usually comes as back-to-back follicles. And as we described, it's more monomorphic. However, the early cases of pediatric type follicular lymphoma, some of them show what they call it marginal zone differentiation. Recent studies try to assess the molecular signature of both pediatric type follicular lymphoma and pediatric nodal marginal zone lymphoma, and they found they have they share most of the molecular signatures. And the recent literature, and now they are talking about they are two histological manifestations of same disease. The next topic I will talk about is this large B-cell lymphoma with IRF4 gene rearrangement. This one used to be in the WHO16 as a subtype of follicular lymphoma. In the WHO22, this one has been shifted from follicular lymphoma to large B-cell lymphoma. It is a rare de novo mature B-cell lymphoma with follicular, diffuse, or mixed growth pattern. And the defining molecular feature for this entity is the IRF4 gene rearrangement. This is the usually present in the translocated with IgG locus. Most cases reported in children and young adults with slight male predominance. Majority of the cases present within the head and neck and cervical lymph nodes. Some case reports has been reported in Bayer batches and in intestinal lymph nodes. Actually, recently I had one case for a 25 years old man who is presented with Bayer batch involvement by this entity. The overall outcome seems to be favorable. Those patients usually treated with the diffuse large B-cell lymphoma protocol, and they respond very well to that protocol. So in histologically, we can see follicular-like growth pattern with some areas of more diffuse architecture. Most of the cases present with combined follicular and diffuse growth pattern. Usually, the follicles are enlarged and rounded, and there is no zonation in the low power. If you go to high power, you will see sheets of centroblast-like cells with sometimes intermixed in some smaller plastic-looking cells. On the immunophenotype, the most important immunophenotype we'll see is the strong positivity for MUM1 immunostaining and the strong positivity for BCL6. So if you have diffuse large B-cell lymphoma morphology in young patient, pediatric or young adult, and it shows a strong positivity for BCL6 and MUM1, think of large B-cell lymphoma with IRF gene rearrangement. It is also shows CD10 expression. Sometimes the CD5 is expressed in around 30% of the cases, and Ki67 usually is high in those patients. So the diagnostic molecular pathology for these cases is the presence of the IRF gene rearrangement, which usually with the IGH locus. However, it's been reported with the IG kappa and IG lambda. And BCL2 and MIC rearrangement usually doesn't appear in those patients. The main differential diagnosis is the pediatric type follicular lymphoma, and this is important differential because pediatric type follicular lymphoma is usually treated conservatively, not like the large B-cell lymphoma with IRF gene rearrangement. The most important thing is pediatric type follicular lymphoma is purely follicular pattern. It doesn't have any diffuse component. It's usually blastoid cells, not like the large B-cell lymphoma with IRF gene rearrangement, which have centroplastic looking cells, usually have static sky pattern. BCL2 is negative, and MUM1 is by default is negative. And if you did the molecular staining, molecular testing, you will see the IRF gene rearrangement is absent in the pediatric type follicular lymphoma. The other differential diagnosis is the diffuse large B-cell lymphoma. Those patients usually comes as in older age, advanced stage disease, and diffuse growth pattern. B-cell lymphoma, this is the new term for follicular grade 3B. This is in the most recent WHO. Also similar to the diffuse large B-cell lymphoma, usually it is a disease of elderly people, and usually they lost the BCL6 in the higher grade follicular lymphoma, and the BCL2 is variable in those patients, but the IRF4 is negative. The next topic is the high-grade B-cell lymphoma with 11q operation. This one joined the WHO in 2016 as Burkitt-like lymphoma with 11q operation. In the recent WHO, it's has been the Burkitt-like has been removed and replaced with high-grade B-cell lymphoma. It is rare, aggressive, mature B-cell neoplasm with Burkitt-like morphology and typical Burkitt-like immunophenotype. The defining genetic event in this tumor is the operation involving the long arm of the chromosome 11 in the absence of MYC translocation. Most cases have been reported so far in children and adolescents and mostly present as a nodal disease. Burkitt lymphoma usually extranodal disease, but this entity mostly comes as a nodal disease. There is some cases reported extranodally in the head and neck region and in the gastrointestinal tract. This is the histomorphology. It is exactly almost similar to the Burkitt lymphoma. Usually have sheets of intermediate blastoid-looking cells with starry sky appearance, mimicking Burkitt lymphoma. The cells usually have dense nuclear chromatin and multiple nucleoli. Compared to Burkitt lymphoma, the high-grade B-cell lymphoma with 11q operation shows more cellular polymorphism and variation in nuclear size. Sometimes they have enlarged nucleoli. The immune profile is exactly the same as Burkitt lymphoma. Usually they are CD10 positive, they are BCL2 negative, and they have almost 100% Ki67 proliferation. Sometimes they have MYC expression, but when it is there, it is variable. As we learned from Dr. Bakshi this morning, MYC immune staining doesn't correlate very well with the MYC rearrangement. Some cases they will have CD56 expression, and the EBER is negative in these cases. And this is important differentiation. Sometimes by flow cytometry, the high-grade B-cell lymphoma with 11q operation, they have apparent phenotypes. Sometimes they present with CD16 or CD56 immune staining. Sometimes they have expression of the CD8, which is a well-known T-cell marker in these cases. And they usually have the absence of the strong CD30. CD30 strong expression is a defining or a common finding in Burkitt lymphoma. So if you have a case which has Burkitt lymphoma like morphology, but it shows these apparent expression by flow cytometry, think of this entity. The defining molecular, as we mentioned, is complex operation involving the 11q chromosome, and this includes many changes. The best testing to detect these numerous operations is the next generation sequencing, because the commonly used FISH analysis cannot detect loss of heterozygosity in 11q gene. So this is the most important differential. Burkitt lymphoma, it is by default is the most important differential in this entity. Usually when you have a Burkitt-like tumor, but doesn't have the perfect immunostaining or perfect morphology, think of high-grade B-cell lymphoma with 11q operation. If you have more polymorphism, if you have weak MYC expression by immunostaining, or you have apparent flow cytometry, or you send it for MYC rearrangement and it came negative, then send it for 11q operations. The other differential is the high-grade B-cell lymphoma, either double hit or not otherwise specified. These entities are commonly present in older age groups. They have more polymorphism, and they have variable immune staining. Sometimes it's difficult to differentiate them based on histology and histological and immunophenotypic features, and you need to send them for molecular gene rearrangement. Diffuse large B-cell lymphoma is by morphology. It has different centroplastic and polymorphic morphology. The immunophenotype sometimes can be overlapping. There is some cases of diffuse large B-cell lymphoma reported with the 11q operations. According to the WHO, it's considered this as unclear, but most recent literature describe these are just part of the diffuse large B-cell lymphoma and should not be included in the high-grade B-cell lymphoma with high-grade B-cell lymphoma with 11q operations. The last category which I will talk about it is the systemic EBV positive T-cell lymphoma of childhood. This is an extremely rare disease. It's put under the umbrella of EBV positive lymphoproliferative disorder of childhood. Most of the other entities present with cutaneous manifestation. However, this one can present with lymph node involvement. It is a rare disease reported mainly in Asia. The first description was in Japan, later on described in other Asian countries and Central America and South America. It is clonal proliferation of EBV infected T cells that usually infect immunocompetent children, and it has a rapidly fatal course. The systemic EBV T-cell lymphoma of childhood has two clinical presentations. The common clinical presentation is an active, severe active EBV infection that is transformed to lymphoma, usually previously healthy child with immunocompetent immune system, present with infectious mononucleosis like clinical presentation. Few weeks later on, the patient developed hepatosplenomegaly, liver failure, sometimes lymphadenopathy, skin rash. The the laboratory testing usually show pancytopenia, abnormal liver function test, high EBV viral loads, and importantly, they usually have low or absent anti-VCA IgM, which is a serological test for acute EBV infection. Although those patients usually present as acute presentation, they have absent IgM antibodies. And those patients usually complicated by HLH, coagulopathy, multi-organ failures, and eventually death within days or weeks. The other pathway, the uncommon pathway, is secondary progression of systemic chronic active EBV infection. When it's involved the lymph node, usually it's present as it's distort the architecture of the lymph nodes with pale areas of atypical T lymphocytes, usually have polymorphic morphology, and mainly expand the follicular area. The normal B cells usually are depleted in those patients. Sometimes you will have extensive sinus histiocytosis with erythrophagocytosis. This represents the HLH component in this disease. The liver and the spleen usually are involved in those patients. In the liver, you will have prominent portal and sinusoidal lymphoid infiltration. In the spleen, usually the neoplasm involves the sinuses, and you will see usually hypocellular infiltration involving the splenic sinuses with atrophy of the white pulp. Immunophenotypically, usually these cases present with T-cell markers. The CD2 is usually positive and bright. CD3 is usually weak. In those cases, CD56 is negative. Other T-cell markers usually show apparent loss, the most common being CD5 and CD7. The cytotoxic markers like the TIA, usually positive. In the common clinical presentation, which present as acute primary EBV infection, the case is usually CD8 positive. However, if it is present as progression of systemic chronic active EBV infection, usually they are CD4 positive. Sometimes they have dual positivity for CD4 and CD8. EBER is always positive in these atypical T lymphocytes. The most important differential diagnosis for these cases is the systemic chronic active EBV infection. Those cases usually present as protracted disease with long duration of the symptoms. By definition, is more than 3 months. You'll have the positive EBV infection as with the lymphoma. Most commonly, it involves the spleen, liver, and bone marrow. But it is the most important thing is the long protracted course and the lack of cytological atypia in those patients. The other important differential diagnosis is EBV positive HLH. This one is very difficult in the differential diagnosis to differentiate from systemic EBV positive lymphoma of childhood, especially in early presentation, as both they have similar morphology in early stages, but usually EBV HLH lack the monoclonality of TCRG rearrangement. Sometimes some cases reported to be monoclonal, and this is very difficult really. The new entity in the WHO, it's called EBV positive nodal T NK cell lymphoma. This is exclusively an adult disease. So if you have pediatric patient, you call it systemic EBV positive T cell lymphoma of childhood. If you have adult patient, you call it EBV positive nodal T cell lymphoma. And for the slide, I conclude my presentation. Do you have any questions?